Let's take this time for a question and answer period.
Yeah, I have a question for Donna Yee. Donna, I wonder, you've described the really important work that you're doing in the community. I wonder if you could summarize from your experience the 2 or 3 most important areas in terms of policy change that would make it easier for the populations that you work with to access and receive good quality services.
One of the issues is that many, Dr. Young talked about the fact that many families have more than one primary caregiver. Oftentimes, one adult child takes care of paying for services, but another family member, another adult child, does hands-on care. Another sister might come into town to give a bath on Wednesdays. Another one might be the one who supervises the home care worker. And if a provider doesn't understand that all 4 of these caregivers have to be intricately involved in the care plan and in planning any changes, then the care plan actually doesn't work. So if the sisters all have to rely on each other, you end up with the message getting deteriorated every time it's repeated. And if there's conflict in the family, then it's the so-called primary caregiver who has to deal with it. So I think one of the policies we do need to change, because we have a lot of forms that we fill out when we let our funders know we're providing services, and they almost always say, who is the primary caregiver? We have an Older Americans Act grant, and they pretty much insist on primary caregivers. And we say, what about the other 4 children we're talking with? What about the time it takes to organize a family meeting? I think the other thing we spend time with family caregivers is helping them think about how to marshal their family's resources. So many times the adult child doesn't feel that she has the permission or the power to call all the siblings together and the aunts and uncles to have a family meeting. And I think that it's often a service provider, a care manager, a coordinator, a coach who encourages her to do this and really enables the family to better understand what care is needed by the care receiver. We're not given a lot of credit for that. That's not counted in our service hours. And I think that's another policy area that, in addition to mentioning all the family caregivers, I think the amount of work and time it takes to help organize a family in providing care over time would be a policy change. I think a third thing would be really understanding this notion of outsiders and insiders. Oftentimes, service providers assume that if somebody accepts a service, that outside, inside stuff doesn't matter. But for many families, every single service encounter is an abrasion with an outsider. And if the mother constantly says, I don't understand why you can't just bring me whatever you're cooking at home for dinner over to my house instead of having somebody deliver a frozen meal or having somebody else cook it. So oftentimes when we're providing support to caregivers, we're not always listening. As Dr. Young said earlier, we're not listening to exactly what they're saying. We're not helping them address the needs that they have today, because we're thinking in a month, in a week, by the 6th home visit. We're really not always attending to the kinds of needs that family caregivers are talking about when we're providing service to them.
Hi, thank you very much for both your presentations. They're great. I have a question for Dr. Benton, If you might expand a little bit more on how programs like Powerful Tools for Caregivers were modified to be more responsive to the caregiving experience of African Americans.
Well, as you know, with Powerful Tools, again, it's an evidence-based practice, so you're not supposed to deviate too far out of the script. But what we did do for Powerful Tools when we were presenting it for the African American community is one thing, they always say you have to have a warm environment, so we made sure that you had food and things like that. Certainly the resources that were chosen, and we brought in resource providers, in the book it says to just have a table. Well, instead of a table, we brought in people, because that's that more one-on-one thing. The video that's used in the Powerful Tools manual is called The Doll Maker. I don't know if many of you have seen it, but it's good in terms of content, but isn't exactly ethnically sensitive across a lot of groups. And so many times we've gotten negative comments about the video, so we'll supplement that video with a different video, but we still use the video, trying to keep fidelity. I'm a researcher, fidelity. But so it's a matter of how we kind of supplement, and then of course, anytime we're doing the role play and examples, we may modify them a little. I'm licensed, I don't want them to kill me. Master trainer.
I want to thank both of you for your leadership for so many years in California. Both your presentations were terrific. And for both Donnas, if you could comment on the acceptance of respite care in the Asian American and African American populations. It's an area that has potential for expansion in public policy, but we know a little bit less about the acceptance in different communities.
Respite, absolutely, excellent. What we have found is, well, I'll give you an example. We had what we call our retreats, and one of the key things is they're called 48-hour retreats, which means you have to leave your loved one home and come to the retreat by yourself. So we were doing the retreats, but we weren't getting a lot of participation from our African American families. So we had to modify our retreats because it was supposed to be you get away, you're by yourself. What we did is, first of all, we had to help people find within family members someone that they could trust for respite and not just be able to say, oh, here's a home health agency. That did not work so well. Secondly, we had to open the retreats so that they could actually bring more family members, as many family members as they wanted, without the person who had the disease, because we couldn't do that, but they could bring other family members. So we would have, just like maybe the retreat would fill up with 3 families, because it would be brothers and sisters and spouses and all come together, and so we may have 2 or 3 families, and that was one of the modifications that we had to make for respite. So you have to look at it differently, and it certainly takes a lot of time with any family to allow someone else to come into the home or to understand the concept of respite. Because remember, respite isn't just about bringing someone else in, it's also a mental state. So we also discuss respite in terms of understanding how to use relaxation, taking breaks, but a lot of the cognitive aspects of respite. So,
I agree. Sometimes in offering respite programs, we're thinking about how to pay for the service so that the family caregiver can have time off. But we found that we need as much time with the family caregiver, talking with them about how they're going to give themselves permission to take time off and what is the nature of that time off. We have so many caregivers who do more work. They take care of their grandchildren. They take care of their, they're taking care of their husband while their mom is at day respite. And so in many ways, talking through what is the meaning of respite and whether or not that's a chance to get something done for themselves, even if they're taking a nap, even sleeping, even going and taking care of their own health care needs. And for many of the caregivers, it's very difficult to do because they're so overwhelmed with the amount of caregiving, the number of people in their families they're caring for. So Respite isn't just throwing money it's not just a voucher program. It's really so much more than that because it's the opportunity to really engage the family caregiver in talking through how she might sustain her efforts over 5 years, over 10 years. We've had caregivers who come to us and they say, well, I've been helping Mom for 15 years and I've been working with all of my sisters. Do you think now, I could get some respite? Because she's feeling like this is her obligation. She's being a good daughter. So we need to do a lot of work with family caregivers. Sometimes it's not just having parties for them. Sometimes it's a meaningful conversation. Sometimes it's helping them connect with a family member that they haven't had a chance to engage with because they're so busy doing caregiving.
Can I just add, one of the things that we found is when we let the caregivers define how they wanted to use their time, sometimes they said, well, we don't want, whole days, we don't want that whole 48-hour thing. Let's just go on a party boat for two hours. Or, can we just go to a baseball game together? So we've had to listen to what people want in terms of respite.
We also found that when we asked family caregivers to plan a respite retreat, they wanted to do a field trip with their care receivers because they felt that respite was being in a group with other people where they could spend time with other family caregivers and Mom could be with other people.
Thank you both for very informative and helpful presentations. I have a question for you, Dr. Yi. If I understood correctly, you're providing education and outreach to many different Asian communities that have different languages. And I was wondering how you handle the differences in language and if you have any models, if you work with translators, or if you have a peer-based model that you use, and if you had any recommendations for other agencies that outreach to communities that speak different languages.
So it's very labor intensive because we go where people are at. At first we organize these workshops and diverse groups would not show up. So we went to where the Koreans were gathering together, where the Filipinos were gathering together. We did not have a lot of multilingual meetings. Sometimes it was across dialects in Chinese, but generally most of the groups were fairly homogeneous in terms of the language of the group. Sometimes it was bilingual English and one other language. We would reach out to people in that community who were bilingual, who would help do translating. We would train that person in the content that we were presenting. Oftentimes, we worked with students. So there are a lot of students who are very bright, very good with the technology, but they're kind of afraid of people. So we realized that these were great opportunities in small groups, in discussion groups, for students who were bilingual to use their language skills and to be really engaged with small groups of people, with large groups of people, and really face-to-face with caregivers listening to their questions. Sometimes one of the issues was that students didn't recognize that they needed better language equivalency. So you might have a mom and pop knowing how to order at the restaurant, but it's different when you're talking about the new advances in care of persons with dementia. And we had long discussions about what they called dementia in the Cantonese community and the Mandarin-speaking community, for Hmong, for Pangasinan speakers, and it was an important part of our engaging the community, but also for them to understand what the nexus of this language construct is between the technology of this caregiving, disease, etiology, all of these things, and then the everyday mom and pop, how do you understand that? So many communities are still using words like crazy when they refer to persons with dementia. So one of our biggest efforts was to really develop a better lexicon of languages and terms without having it, you know, like at the end of your stuff where you say, here are the ABCs. Well, we're trying to figure out a way in more communities to use everyday language to describe behaviors and issues that can be brought up to service providers.
So thank you both. And both of you mentioned the importance of community and are working with communities. And Donna, you talked about having a broad view of what is evidence-based and having it spring up from communities. I wonder if each of you would comment on on whether you think, and if so, what you think, that federal policy could do to facilitate the mobilizing of communities to, say, thinking of mapping resources and connecting caregivers. What could federal policy do to make that easier?
I think that community organizations need to be a substantial part of the huge changes in how we're organizing care and how we're providing care. Hospitals seem to think they could go their merry way, ACOs could go their merry way, but if community providers aren't involved in helping those services be acceptable and be accessible to people, to elders in the community, it won't work. And sometimes it's organizing a whole family construct, the caregivers together with the care receiver, to learn about a service, to think about, you know, so do I really need a navigator? Well, I need someone to help me go to the doctor's office. I need someone to help mom get from the front door because they keep leaving her off, but she doesn't know how to actually get to the office. And then afterwards, she doesn't know how to go to the pharmacy to pick up her prescriptions. So I think there's a lot of dialogue that needs to happen between these new service systems we're creating and community groups. And it's not about dumbing it down, it's about making it accessible.
To add to that, because I mean that was really quite a full answer there, I think it is important if we begin to, you know, I said respect, and part of that respect is respect for time. The policies currently don't necessarily pay for you taking time to talk about things. They don't want to pay for the amount. They feel like, oh, outreach shouldn't pay as much as direct service. And I think that when you're working with community-based organizations, the time that it does take, the effort in outreach, and the people involved in the outreach all should be part and parcel of any policy, and that you should monetize that in a way that respects the value of that time. So I would just add that.
To give them a round of applause. Thank you so much. Very invigorating and thought-provoking comments. Thank you so much.